Let's just start. We have about 44, so let's go. All right, good evening from
All right, let me
New
go
York
ahead.
City. This is Bob Akivi. It's 7 o'clock Standard Eastern Time. Today is a cloudy day in New York City, and you might not hear the cheering from the healthcare workers outside my window, but that's the tradition here in a lot of cities. Hope all of you and your families are doing okay in this time. Today, we are very excited. We have a session about management of the neck. We have Dr. Charlie Kofi from UCSD and Dr. Shad Zender from Cincinnati presenting cases, and Dr. Arnold Bewley from UC Davis who will give us another case. I have a very brief update from a case that I presented a month ago to show you what happens and the further management of the case. Dr. Zahn will join us for the update of the imaging, specifically how to do CT guided biopsies for these cases. All right, we got a full session. Let's get it started. Dr. Kofi, you're up first. Please share your screen, and looking forward to see your case.
Will do. Thanks so much, Doc. And
Dr. Moore will monitor the chat box for the fellows. If you have any questions, you can ask, and we can discuss with the discussant. Dr. Jeff Liu is also on and as a discussant, and if there are any other attendings, please let us know and welcome your comments.
I see Dr. Weed and Dr. Ridge on there as well. If it's any consolation, Babak, to those on in New York and the East Coast, it's cloudy in San Diego today as well. So you're not missing a thing.
That's never possible.
Let me go ahead and it's rare.
Okay, go for it.
All right, you guys getting the screen?
Yeah.
Okie doke. So for the discussants, but most particularly for the fellows, what I want you to think about here while we're talking about this case is what it is that makes elective management of the neck in medullary thyroid carcinoma unique among all of the head and neck pathologies that we see. So what is different about managing the neck electively for these tumors versus every other histopathology we talk about? About 2 months ago now, I met a gentleman who was being surveilled for a history of adenocarcinoma of his colon, and routine surveillance PET CT demonstrated an FDG-avid lesion of the thyroid. He was referred to his endocrinologist or an endocrinologist. Sorry, I'm getting a lot of feedback. Is it on my end?
It might be you. Please all mute your microphone.
Perfect.
Thank you.
Okay, thanks guys. Sorry about that. Single FDG-avid lesion of the thyroid evaluated by his endocrinologist, who performed ultrasound demonstrating a single sub 2 centimeter nodule hypoechoic in the left lobe of the thyroid. As mentioned, his prior history was notable for adenocarcinoma, first treated surgically, followed by adjuvant chemotherapy in 2010, recurred in 2019, and underwent chemoradiation for that about 1 year prior, has been disease-free since. He's also had a history of vasculopathy, underwent a BKA about a year ago, prior DVT and IVC filter, but he's not currently anticoagulated. No family history of any thyroid malignancies, MTC or otherwise, nor any family or personal history of hypercalcemia or other endocrine tumors. FNA was performed consistent with medullary thyroid carcinoma, and he was staged at that time T1B N0M0 stage 1 MTC. So for the discussants, what would you do next by way of working up this gentleman?
I thought all of the people in California are healthy. Where did you find him? Did you import him from New York?
From Las Vegas, actually. I actually have a pretty busy Vegas clinic, and that's where he's from.
That makes sense. Okay, well, the stage 1 thyroid, medullary thyroid cancer. So as you all know, we do have guidelines through the ATA to how to approach medullary thyroid carcinoma. How old is the patient again? 70?
72.
72, so it's on the older side. But in general, for any medullary thyroid carcinoma, nowadays, you know, you do the routine, you check for the red proto-oncogene, and then CEA, calcitonin. We do rely on ultrasound here for our thyroid imaging, even when they have other imaging. Elsing's on the line. Elsing, what would you recommend for imaging of the medullary thyroid carcinoma? Do you have any other specific modalities?
everyone. This is Atina, one of the radiologists and molecular imagers, nuclear medicine people. For medullary thyroid cancer, currently we advocate for a different PET agent, dotatate PET. It has been shown to have higher sensitivity than the FDG to medullary thyroid cancer, given the somatostatin receptor type 2 positivity. Having said that, not every patient comes to us saying that I have medullary thyroid cancer, what should I get? So most of the time we end up imaging those patients post-operatively. So personally, I would prefer baseline dotatate before the surgery to see what the original tumor looks like. But if I lose that chance, we request pathology stain for somatostatin receptor type 2 on the specimen that came out so that we can decide whether the specimen stains positive for SSTR2. That means that they will be a perfect candidate for dotatate PET. If they stain negative, then we again switch to PET, FDG PET. So we have two different options here.
Yeah. So this is dotatate is a new scan that I just wanted to offer the others to know about, that there are some centers that we do have the ability to do dotatate, and that's more sensitive for medullary and in general for a lot of neuroendocrine tumors. And that's what we do have the capability here. Actually, we can do dotatate MRI. We've become so fancy nowadays, but it's something to consider. So that's how I would approach it. Mike, Arno, or Chad, any comments, or Jeff? Others?
Charlie, can you just go back one slide to the PET scan? Just want to make a side point briefly that it's not uncommon now with a lot of patients who are being observed for one oncological issue that they show up with a thyroid nodule that's PET avid. Yep. And I just want to comment that PET avid lesions have about a 30% chance of being malignancy. And so in general, I usually advocate for working these up. And if the FNA is sort of indeterminate, favoring surgery. I mean, you might send an indeterminate nodule for subsequent testing, like gene expression classifier testing. But I just want to comment that you should have a high index of suspicion with a PET avid thyroid nodule. Just want to bring that point home. But in terms of workup for this patient, Charlie, do you mind just going to the next slide so I'm on the same page? Agree with everything Babak said. I also agree with getting a formal ultrasound, and in most medullary thyroid cancer cases, it's not, they're not that common depending on your center you're at. But I would always get cross-sectional imaging, starting with a CAT scan with contrast. I really want to take a look at lymph nodes, both in the central compartment and in the lateral compartments, because we know that medullary thyroid cancer does extend the lymph nodes quite often. And then the CEA and the calcitonin are definitely biochemical markers. I'm curious to hear from my colleagues how they do the RET workup or any kind of FEO workup, because I tend to sort of, I don't have like a very good personal protocol. I tend to talk to my endocrine colleagues. What do you guys usually do? Some people do urine, some people do peripheral blood, and whether or not they get that genetic testing early on or sort of make sure they work it in along the way. I'm kind of curious to hear what my colleagues think.
Yeah, I think my workup is similar to what's been discussed. I agree with Babak. I do a lot of times go back and lean on the guidelines by the ATA, especially in instances where they really specify even the type of mutation within the RET gene. That'll kind of stratify your risk. Obviously, this is a fairly old patient, but in a patient who was younger, where you do run the risk of having other endocrinopathies, it kind of will help guide you in how aggressive you need to be with the evaluation of that along with it. But as far as imaging workup and everything, I would agree with all of that. And obviously a physical exam, including a assessment of vocal fold mobility.
All right, so all those points I think were spot on, and I will say to Mike's last point, in this case the exam was ultimately and effectively normal, so no palpable thyroid mass, nothing I could palpate in the neck, and he did have intact bilateral fold motion. So he actually came to me kind of already fairly well worked up, courtesy of his endocrinologist. So initially the PET kind of leading things off, as I mentioned, this was an incidental finding, followed by a formal ultrasound, which demonstrated a single well-defined 1.4 centimeter nodule in the thyroid, no nodes visible either in the central neck or the lateral neck by ultrasound. His metastatic workup and kind of MEN workup consisted of cross-sectional CT imaging contrasted of neck, chest, abdomen, pelvis, which did not show any adrenal tumors nor any evidence of nodes in the neck or elsewhere, and no evidence of metastatic disease. Now, as mentioned, he's a 72-year-old. The chance of this being familial or the hereditary MTC is low. This is much more likely going to be sporadic. But that said, germline RET status was assessed, but was not known at the time that he was referred to me. TSH and calcium were normal, as would of course be expected. His urine metanephrines and catecholamines were likewise normal. Calcitonin was elevated to just over 200, and CEA was also elevated to 5.6. So with this information and the workup hopefully completed, what are folks' thoughts about how to manage this gentleman surgically?
So sorry, I missed my audio for a second in this part of the conversation. Great case. So I think I'm trying to remember if the guideline says if this calcitonin is less than 200 or 250, you only need to do central compartment and you don't need to do prophylactic or elective lateral compartment. I have to double check myself, but I think in this case it would be reasonable to do a total thyroidectomy central compartment and see what we see. Obviously, if there is any doubt, the side of the tumor doing a ipsilateral elective neck dissection would be very reasonable as well. That's how I would approach it.
And I think in a guy this age, it's not unreasonable to monitor his lateral neck too, especially with that relatively low calcitonin. So I think I would certainly put an ultrasound on his neck in the office. And if nothing looks suspicious, just do the total thyroid and central compartment.
Okay, Mike and Arno and Jeff, others.
So
Yeah.
I'm trying to post there's an option to post into the chat a file. Let me see if I can get it to work. There's this guy, I think he's in Germany, Dreyer, who basically it's like the medullary thyroid cancer like sinkhole for like seems like a large part of Europe, and so he's published like a series of like a couple hundred patients. Oh, there you go. Thank you.
Gralle.
Yeah, I was not.
Asking it shall be done.
I was just totally, I'm not a plant, I promise. But basically, this exact, which is table 5 from that study, but I'll try to post the file so people can download it, is an excellent study. And it basically, I think this is where biomarker-driven decision-making for this disease is extremely helpful. And realizing this is a single institutional, practically a single individual's series, but it is some of the best data that we have based on patients. And I've used this quite a few times trying to make a decision whether or not I should perform, if you're doing the ipsilateral neck, whether you should do the contralateral neck and a number of different other things. So in this case, you can see the at the calcitonin of about, what's 201, so it's like right over the edge. But I think definitely central compartment is appropriate. And I would be sort of plus minus on the on a lateral neck dissection. Because you can see the numbers here that Charlie has nicely outlined. So I would favor central compartment neck dissection as the initial step.
Okay. I see Dr. Drew Ridge as a present. Is this the Dr. Drew Ridge? Am I?
The legend.
Would you like to make a comment, Dr. Ridge?
I think that the discussion so far has really been on point. Gralle has done great work in this field, and I think this is a really useful monograph for treatment planning. It's essentially the rule that when patients have palpable medullary thyroid cancer, they already have lateral neck disease that correlates quite well with elevated calcitonin. So we find ourselves trying to decide what to do when lesions are incidentally discovered. And I think this is really instructive. And I think many would perform a lateral neck at the initial sitting.
Great. Okay. All right. I think we all agree that at minimum, doing a central is required. Okay, Charlie, let us know what you decide.
All right. And then so that discussion was all absolutely point on. I won't really go into this anymore because you guys already hit on it. But just to highlight a couple of the ATA guidelines and also the fact that these are low-grade recommendations, grade I recommendations, so kind of no appendix. But if the neck is radiographically N0, and the calcitonin is elevated significantly, we can consider lateral neck, just as you guys have discussed. And then subsequently, if the ipsilateral neck is involved, but the contralateral neck is uninvolved radiographically, elevated calcitonin above 200 would be grounds to consider and have that discussion. And so with this patient, I did have that exact discussion. I said the recommendation, and this was discussed on our tumor board as well, is at minimum for total thyroidectomy in central neck, and then we talked at some length about whether or not to operate on the ipsilateral neck as well. And ultimately came down in part to his decision, which is to say, I discussed what we would do if we didn't operate on the lateral neck and rather observed, and the possibility that if he had a calcitonin spike subsequently and developed disease, he would come back to the operating room. And in typical Las Vegas veteran fashion, he said, let's just do it all now and get it done and not have to do it again, or at least hope for that. So indeed, that was kind of patient-central decision-making. We did operate on level 6 as well as levels 2 through 5 on the ipsilateral side. And the final pathology demonstrated a 2.1 centimeter tumor with no LVI or PNI. There were 4 nodes involved total, including a single paratracheal node, but 3 in the lateral neck. Yeah. And a bonus PTC. I think honestly, at times you could swing a cat by the tail and hit a PTC. His post-op PTH fortunately stabilized, and he went home on post-op day 1. So ultimately upstaged to pathologic both T2 and in 1B, so stage 4A. And we talked about a plan for him, and can certainly defer to the group, but ultimately, based on the best evidence as well as the ATA guidelines, elected to observe him with minimal neck disease. So although he did have 4 nodes positive, it was microscopic nodal disease with no E&E. Did not think that adjuvant radiation would offer him significant benefits either in terms of overall survival or local regional control in this setting. So we're going to check his baseline biomarkers in about 2 months from now. And then just as relates to the incidental finding of PTC, clearly no role for radioiodine here. And really the one question was whether or not we manage his thyroid replacement at a euthyroid dose or a suppressive dose. So we'll see if he has any detectable thyroid globulin, and we'll defer to his endocrinologist in that regard.
Great. Fantastic case. A couple of points we have to wrap up. It's 20 minutes is up. I think this is not uncommon that you do a lateral neck that looks completely normal and you find 2 or 3 nodes that are positive. It's very common for this disease, and majority of time, if the lateral neck done in good hands with minimal morbidity, nobody can blame you for trying to do that. In terms of the burden of the disease, we actually we presented last year at American College of Surgeons that the positive node to the dissected node index is a much more sensitive way of determining survival. So if you calculate your index, which is less than 0.01, that means that this patient is very good treatment. And if you look at the curve that we published, it's quite high. So I personally would not do anything else. Let me, in the interest of time, would anybody of the panel would recommend radiation or any other treatment, or everybody will be in favor of observation? Let's just go down the road. Chad?
No, in this gentleman with his age, I don't think he would radiate based on his disease burden.
Okay. Anybody would recommend anything else? If not, we're just going to move on.
All okay. Right. Well, so let me finish with, I guess, just one quick observation, which is to point out the fact that for MTC, as I alluded to at the start, the one thing that makes this unique by virtue of having this biomarker utility is this is going to be the one pathology that you would consider doing a comprehensive neck dissection, 5 levels of the neck in the radiographically in zero neck. I don't know that there's any other context at present in head and neck cancer world that's the case.
All right, very good. Personally, I do not dissect above the above the spinal accessory nerve in the posterior triangle for these, but I think other than that, nobody will criticize you for it being comprehensive. Okay, Dr. Zender.
All right, I will try and make this work. Let's see here. Oh boy, lots of options.
Just share a screen.
Give me 1 second.
All right.
While Chad is working, I would just say on that last case to really push for the PET dotatate for follow-up, because the mediastinum is always at risk in these patients.
Absolutely.
And
definitely.
yeah.
Go ahead. Yeah, definitely the calcitonin and also the dotatate, I think it would be the better. Although as a 72-year-old, you know, with his I'm much worried about his with the BKA. Yeah.
All right.
Okay.
Sorry.
Chad?
It made
No
me,
worries.
I had to change my settings, so I apologize.
No problem.
Are you guys seeing now?
Yeah, now we can see. Go ahead.
So we'll start with 76-year-old male, T4N1 SCC of the larynx, status post-chemoradiation, underwent a salvage laryngectomy and neck dissections in January 2016. He now has some right fullness in his neck and some tenderness. In all honesty, I added the fullness and tenderness. He had kind of a woody neck. He had been salvaged several years before. And we were imaging him before a revision pharyngoplasty because he was having worsening symptoms, swallowing, but really asymptomatic in the same woody neck he had had for years. But in this setting, you know, with this gentleman's symptoms, if he's having pain, there's concern for recurrence. What's sort of the folks' initial imaging, and I'll open it to the crew. What do you think's appropriate? Ever an ultrasound in this group? CAT scan, PET scan? What's your go-to initial imaging test?
That's a great question. How long ago was his chemo-RT?
About 4 years ago.
Yeah. This is one of those challenging situations, and we have all been in this scenario that you have a patient that you do have this kind of vague pain that you really don't know, and your exam with this woody neck and prior surgery is really not very conducive. To be honest with you, you know, as you know, NCCN guideline does not recommend routine imaging in asymptomatic patients. But when it comes to symptomatic patients, they don't say anything. And I think it all depends on your local expertise and the comfort level. I think at this point, starting with just a normal CT, the regular CT scan is not unreasonable. If you have the possibility to do PET CT is also not. But I'm not sure if anybody knows exactly. I mean, we do have a PET MRI here, but I don't advocate for PET MRI in everybody. I think that's one of those things that it's a little bit, it's an art, and I am not sure if I have the answer. I'm curious to hear others.
I mean, I think a lot of it would depend on if you had any imaging after surgery before this time, because everything's going to obviously be distorted. And so a comparison image would be very helpful. Certainly don't lose by trying an office space ultrasound. In my hands, I don't think it would be reliable in picking up somebody in a operated wound bed unless there was something focally there. So often would start with a CT with contrast. PET may have run into the roadblock of insurance coverage if it's not biopsy proven recurrence. That's the only concern there.
Yeah, I would favor CT with contrast.
You would do what?
I would favor CT neck with contrast as the initial work, as part of the initial evaluation.
Perfect. Others, Charlie, Don, Dr. Ridge.
Yeah, I certainly echo what Mike said in terms of the real challenge of ultrasound in these necks. On the other hand, if I've got the patient right there in my clinic and I've got the ultrasound right there in my clinic, you know, very low threshold to put the transducer up, and if in fact I do see something that looks, you know, clearly targetable, I can go ahead and assess that with a needle right there. But if I'm left scratching my head after the ultrasound, I'm definitely going to get probably contrasted CT neck.
Perhaps I missed whether this was the previously dissected neck or is this the undissected side?
He had actually had bilateral neck, so this is his right neck at this time, which was a previously dissected neck that had disease. And he had negative PET scans too, to Dr. Moore's point, just to add that.
I think that somewhat informs what I'd expect of ultrasound, so I'd probably start with a CAT scan.
Very good. We have one more guest tonight is Dr. Jennifer Wong from MD Anderson. Hi, Jennifer. She joined us last minute. Was very gracious to accept. Jennifer, what would you do at MD Anderson?
Yeah, so thanks for having me on. We at MD Anderson don't do our own office-based ultrasounds. So in this situation, I agree with what's been already said, is that we start with the CT with contrast, but we often would set them up with the ultrasound with possible biopsy by our radiology team at the same time.
So let me ask our neuroradiologist, Dr. Zahn, would you recommend a fancy PET MRI, or you start with the CT or PET CT?
I mean, I would like to see PET MR in probably any head and neck case. But in those cases, when they are surgically treated, when they receive chemoradiation, doing a contrast enhanced CT takes maybe 5 minutes laying on the scanner table, but doing an MRI will take at least half an hour. So during that half an hour, the patient needs to not swallow, not move, and keep very still for the image quality. It's really very hard in those radiated neck patients and when they come with woody necks. So the patient comfort really defines the quality of the neck. In that particular case, I would like to start with PET MR, but contrast enhanced neck CT I think is the most reasonable option.
Excellent, thank you. So this is the challenge that we always have to remember, that doing an MRI for patients are not easy, especially when they have neck pain, neck fibrosis, sustained. Lying flat for half an hour might not be easy. All right, Chad, let's continue.
Yeah, absolutely. And that's what we did. And I think I've got a few images here with this first image on his right side. You can see just posterior to the carotid after it's bifurcated there. You lose your planes. Now, obviously, these are operated necks, so you're going to lose some of that. On this next set of images, you can see more disease burden as you go down inferiorly, and not great planes between it and the carotid artery. And I'll let you guys look at this, and if anybody has anything to add. Obviously, got a big ALT stuffed in there from his laryngectomy, but.
Yeah. Oh, boy. Yeah, I agree with you. I think there is a plane, but it might be my imagination. Obviously, these are limited imaging. So in these cases, I don't know. I don't know if the PET will show you more than, obviously for distant necks, but that's not very high. MRI, do you think MRI would be more helpful? I'm not 100% sure, to be honest with you. Anybody else would do anything else?
I mean, I would get a PET CT. I think I would be interested to understand whether the patient has only recurrent regional disease versus any disease elsewhere. I think it'll inform not so much a decision making. We'll be talking about management of the neck shortly because that's a topic, but I think more just sort of the global aspect. If it's disease only in one place versus disease in multiple sites, I think it's very important to know.
Definitely. Mike, Arno?
Yeah, I mean, it looks like a pretty ominous recurrence just based on the borders of the mass and location. Maybe you could get it away from the carotid, but certainly based on that image, looks pretty concerning. Either that or he's got a very hot plaque in his artery already. And it looked like it was kind of sucked into the prevertebral fascia on a pretty wide plane. That combined with kind of the extracapsular appearance of the borders is all pretty concerning for ability to easily remove it. Yeah,
it's going to be a challenge. Well, we can get all. Go ahead.
No. I was going to say, I think before we proceed, I'm curious what others would do in terms of number one, any role for a CTA, and number two, or some sort of angiogram, or number two, based on this imaging, does anybody have enough, and Dr. Ridge in particular maybe, or, just in terms of their threshold to consider resection of the carotid artery and whether you get a balloon occlusion versus bypass and how that comes into the fold with a patient like this?
Sure. I'll be the sacrificial lamb here and go first. I'm memorial trained at the end of the day, and we were not very keen on sacrificing carotid. And in general, we thought, and this is all anecdotal evidence, it's not clinical trial, but if the disease is extensive enough that you have to resect the carotid, you're not going to help patient that much. But Probably not, but there are cases. But I would be interested to see how others approach this. Let's go around the table.
This
Whoever
is
wants to go
true.
next.
I hadn't expected to be braced on this, so I didn't really carefully look.
Sorry,
But it doesn't seem to me
You're
as
among
though
friends, Dr. Riggs.
it doesn't seem to me as though the carotid is circumferentially involved, and it's in that situation. I wouldn't seriously entertain replacing it. I think it's also worthwhile to remember that there's no point in increasing radicality in a single domain of your operation. So replacing the carotid is going to make you feel better of about perhaps 20% of the circumference of this thing. And your concerns about the prevertebral fascia are, I think, very reasonable ones, so that we can go through a lot of effort to replace the carotid and feel a little better about that margin. But other margins are going to be thoroughly worrisome as well. I wouldn't think that carotid replacement's likely to be necessary in this case. I'd like a more sophisticated imaging response from a radiologist surrounding the amount of circumference involved.
One other question I would have too is, the MR actually may be helpful in looking along nerve roots. Sometimes these are perineural recurrences along cervical rootlets. This may just be extracapsular disease that's starting to blossom, because I doubt it's a missed node. I mean, it could be, but if there was a thorough clean out before, then it's likely either extracapsular disease just coming back or disease along a rootlet. So check them for a Horner's. The progressive pain, a lot of times this can be perineural disease tracking along rootlets, which sometimes may be more evident on MRI. And certainly those things would be kind of deal breakers. If you see that, that your ability to get any sort of semblance of a true margin is negligible. But if it seems more confined to what we've seen here, then I guess you could consider it. It would still be a real Hail Mary.
Well, I think in the years to come, I'm going to quote Dr. Ridge that it doesn't make sense to increase radicality in one aspect of the operation. That's a great quote. Let me ask Elson. Elson, do you think MRI would be helpful here, in particular with the two aspects, perivertebral fascia and the carotid artery?
MRI. So MRI is like a sharp knife. In those cases, it probably will overcall the findings because of all the inflammation. There will be edema. There will be lots of enhancement. So I still like contrast CT for defining the degree of encasement. And here it definitely looks less than 180 degrees, even maybe close to 120. So, but not CTA per se, because CTA, the contrast timing is very early. What you want to see in those cases is the enhancement between the mass and the carotid sheath and the prevertebral fascia. So I would run a delayed CTA, normal 70-second post-contrast, and a delayed CT contrast, not CTA. I will do delayed CT imaging in that case. But on MR, we do have a high-resolution sequence, and I think I showed two cases during prior presentations. When we do post-contrast KISS imaging with 0.6 millimeter resolution, we can give you an exact answer, but not with the routine store contrast T1, T2 sequences.
How long does that take to do 0.6 millimeter MRI? Jesus.
Yes, well, I have to sit at the scanner with the text and have to scan myself most of the time, or remote into the machine. And this case, I'm assuming this is probably craniocaudal 3 centimeter. It will take at least 6 to 7 minutes.
Okay.
On sequence.
So I have to
this is also where I'm. Sorry,
go ahead.
I would have a goals of care discussion with this patient, right? I have to recognize that I cannot do a compartmental dissection because the compartments are gone. He's already had a nodal dissection. And so realistically, as everyone has alluded, the chance of achieving a true meaningfully margin of negative resection, even with aggressive resection extending to and including the carotid, is going to be low, such that if surgery alone is all I've got, I don't know that I'm going to put him through that. This is a patient who would be offered any and every clinical trial option that he may have available. And that may include surgery as a portion of it. But as soon as he sees Ezra Cohen, he's going to have 8 immunotherapy options laid out in front of him.
Yeah, I think one of the important parts there too are the time of recurrence, right? We all know that if somebody like this recurs within 3-6 months, 8-9 months, or not recurs then, but within the first 9 to 12 months, their prognosis is a lot worse than in a gentleman like this who's 4.5 years out or 4 years out. And to me, that's a big factor in my aggressiveness. And this guy is from good old middle of nowhere, Ohio. So he's all about whatever we need to do to get him taken care of. And so in the interest of time, Babak, are you okay if I keep going?
Yes, absolutely.
So just with that, I agree with most of what's said. Based on that imaging, I thought I was as likely to fail along the paraspinal musculature, the cervical rootlets, as I was the carotid. And it seemed like that was not enough that I went down the path of carotid resection. And so this is an illustration of a gentleman I took care of similar that had a resection in this way. And going down a different path, we actually were able, this isn't his neck, this is another gentleman's, but we were able to clear it here. But really, we had actually resected a fair amount of the cervical rootlets into the paraspinal floor, and that's where he had some positive disease. I think the other point to what was mentioned is in these patients, certainly if they're several years out, getting down to microscopic disease and getting healthy vascularized tissue in there so that you can, retreat with hopefully less morbidity has had, some anecdotal success. But I think the biggest thing is time to recurrence. And we know the later they recur, the better the outcome. And salvage surgery still certainly plays a role in that. So with that, my next, just to the group, what are some of the reconstructive options? Are there any thoughts or considerations when facing a defect like that?
Yeah, that's a great point. And you really, to summarize, basically, at the end of the day, even as Charlie said, with the 20 different clinical trials that we have, let's keep it very simple. It's basically the decision is to cut or not to cut, because that's the main viewpoint here. And I agree with everything you said. 4 years is long enough that we all would consider, especially single-site disease. In terms of reconstruction, I'm a big believer in having vascularized tissue there. You could do a quick and simple, dirty PEC, or you can do a nice, beautiful ALT. You can also, in that location, you can bring back you can be as fancy as you want. You can do, muscle only with a skin graft. You can do musculocutaneous. You can do anything you like. That they are all possibilities, and it all depends on what's the best for the patient and what you are more comfortable with. Seems like you did a big, good old PEC there, which is a great option, and to give you the option for re-radiation possibly.
Just curious about the other folks, ever in this case, or what would drive you all to a free flap?
I think you don't have a lot of vessels from the picture that you looked at. I mean, the jug is already gone. And so the real issue is, I don't think there's anyone who would disagree with putting in non-previously radiated tissue there. But I think the PEC flap, like a rotational flap, really gives you the most robust option for what I think is going to be a very, harsh environment. So, and your vessels are going to be not great at best, and maybe even completely absent. You have to pull in a loop somewhere. So, I don't do any recon, so it's easy for me to ask someone else to do it. But I would still favor probably the PEC flap like you did, just because I think it's straightforward. I think it's robust, and I think it's what you need. Whereas if you put in a vascular anastomosis with vessels that aren't great, I don't think that you're going to be, there's real risk there. If this falls apart, you have a very big problem.
Yeah, definitely need tissue. Yeah,
I would take him with the intention of trying to do an ALT from his other leg. He'd know what the morbidity of that is, so presumably he would say that didn't bother me too much. B, you define your vessels after your neck, and if you don't have them, obviously the PEC flap is the fallback. But the one caveat with the PEC, and I like a PEC flap, I do a lot of free flaps, but a PEC flap is a great flap, is when you combine that with an extended radical neck dissection, the morbidity for the upper extremity is really amplified. So that would be why I would really look hard for vessels to do an ALT.
I agree, and that's a great point that I'm glad that Don brought it. if we are thinking about these operations, it's not just the length of life, it's also quality of life. And don't underestimate a dissected radical neck plus a pec flap. That shoulder is really, especially if it's the dominant hand, you really want to think about it. And a lot of time, even in the previously dissected neck, you might be able to find the transverse cervical vessels, and those are very good vessels that you can use to use.
Sometimes it looks like this. And I will say, I agree 100% with Don. And the point of going down this path was that, and you can do this without necessarily burning the bridge of a pec flap. And this is another patient, just to illustrate, is you can actually take branches of the thoracoacromial trunk, and in particular the deltoid branch, and then you've got your cephalic right there. You can clean that out, flip it up over the clavicle, and that, believe it or not, you can get reasonable length. Now you have to have the right flap and the right defect for it. This lady here, this is, I thought I put that other slide, I may not have, but you can see here, this was an osteocutaneous radial forearm where we dropped it down in the neck, and that's right over the clavicle. But just to illustrate the point that, especially with the defects we showed, it is not hard, and you can do it without burning the bridge of the pectoralis flap later, to get vessels that are well out of your radiated field and give your flap a much better chance without having to go to like the mammary vessels or something like that.
Okay. So Chad, in the interest of time, for that patient that you discussed, what did you decide and what happened to that patient?
Well, we resected him and he got an ALT. He's up getting proton therapy right now at our northern campus, and he's done quite well. He's a wonderful gentleman. So fortunately, I mean, but it's early out, so we'll see how he does.
Okay, great. Thank you.
Were there any margins that were positive on that resection? Like,
So not the carotid sheath was clear, but it was the paraspinal, the cervical rootlets as they were exiting in that area.
Yeah. All right, to summarize, again, as I said, it's really the decision is to cut or not to cut. And that's a very important decision. Obviously, there are a lot of clinical trials right now. I'm not sure any of them have been proven to be more effective as surgery up front plus -3 radiation. But these things coming down the road, and remember, if you're doing this, you need to have a plan for reconstruction. You need to have a plan for adjuvant treatment. And every once in a while, 4 years out, you might be doing well. Okay, great, thank you.
Yeah,
I am going to
was asked about, and I was actually about to ask a similar question. Is this somebody you would consider brachycatheters underneath your flap?
Yes, we do consider that at NYU. Absolutely.
We use the cesium, and we actually have a clinical trial we've just gotten where we're combining interstitial cesium, and hopefully the Jefferson crew and the Case crew can do it as well, but using interstitial brachy with cesium plus immune therapy in this cohort. So I definitely think it's got some value.
Okay. All right, so we are trying to be ambitious and in the next 15 minutes present 2 cases. One is just an update that a quick case I presented a few months ago and kind of got people all interested. I'm just going to go over, and Elsie's going to show the images, and mostly Dr. Wong from MD Anderson going to discuss some new findings for this. So this is if you remember, for those of you who were here, it's a 60-year-old man, healthy, had a thyroidectomy neck dissection back in 2007, 13 years ago. At that point, he had a T3N1B1, which they first thought he had a kidney met, what wasn't really a met, but he had bad node disease in his neck. He had positive extrathyroid extension. He had 23 out of 47 nodes positive with E&E. Specifically, he had on his carotid bifurcation, he had 2 lymph nodes positive. He received 200 of radioactive iodine in 2007. He was NED since then. He was followed by another surgeon. He came to me for left neck pain. I felt a mass on the left side, but I thought it's just a prominent carotid bulb because of previous neck dissection. He doesn't have anything else. Specifically, his voice was normal and his 12 was also normal. But because of his pain, and he told me that he can't sleep, I got an MRI. Elson, can you share us the MRI, and then we go from there? Dr. Zahn? I think you're on mute.
Sorry. Okay. Yes, I was on mute. And so, is it? Can everybody see this 2x2 screen? PET?
Not yet. Share the screen.
I thought I did.
Okay, now we can.
All right, perfect. Yes, so this patient at the beginning got the MRI. We are looking at a post-contrast MRI. This is post-contrast T1, T1 star, and you're looking at a left carotid space versus level T2 mass. So our initial thought was this was in the level 2 going into carotid space, but then the patient had a history of carotid space positive nodal biopsy. So anyway, we're looking at a left carotid space / level 2 mass. It is bright, it enhances, and it looks ugly with infiltrative, ill-defined features. So the patient got a PET. There is no disease elsewhere in the body, chest, abdomen are clear, but you are looking at a very FDG positive mass, which is SUV of 22. And when you scroll through, there is a surgical clip just at the same level here that kind of helped us to define our next move. So we're looking at the mass from imaging properties. This peripheral enhancement looks necrotic, but SUV is pretty diffuse, so it tells us that it's not necrotic. But anyway, so this ill-defined carotid space mass all the way to the hyoid up to the prevertebral muscle level didn't look really fun to us, and then we decided to do biopsy. This is a CT guided biopsy. The surgical clip helped us to define our pathway, and we went right medial to it, did 3 cores from here, and got the results.
So this is the point that I wanted to make. We did an FNA here, and the FNA was not conclusive. And then, you know, in the old days, we didn't have the technology, but nowadays you can actually do a CT guided core, and we got adequate core that we had enough tissue to send for CytoSeq and for Oncomine, which is our own panel, similar to Foundation One, that we can check for all fusions and everything. And this was done as an outpatient. Patient tolerated well without any stroke or anything. Credit to Elfin and her colleagues with their excellent technique. And just for, you know, for the audience, these can be done minimally invasive. We don't need to then open biopsy, especially when you're worried about the poorly differentiated thyroid. So if you just give me the screen back. Now, the final pathology was consistent with poorly differentiated thyroid cancer. And this is the FNA, the positive for malignancy. And this is the CT guided biopsy, poorly differentiated thyroid cancer, BRAF negative. Interestingly, it was NTRK positive. Share the screen.
That's good news.
Well, I thought so, and it was also TERT positive. So I discussed this case with Jennifer from MD Anderson. That's the main area of her research is poorly differentiated anaplastic, and also with Eric Sherman from Memorial. And we had 2 slightly different recommendations. Obviously, if it was BRAF positive, everybody would recommend that to start with BRAF inhibitors. And Jennifer can explain to you their consideration at MD Anderson. And then, but BRAF negative is a little bit different. So Jennifer, the floor is yours.
Okay. So the first thing I was going to comment on for the fellows is the presentation here, which is pain. And that's always like a big red flag for me when a previous thyroid cancer patient comes in and they complain of really bad pain, particularly pain that's keeping from sleeping at night. So that always raises my lowers my threshold for kind of investigating and thinking of badness. And we also here at MD Anderson do core biopsies for these thyroid cancers that we're worried about for poorly differentiated and anaplastic. And our staging workup for anybody who comes back with a ATC-like tumor includes a PET CT like you've done, as well as a brain MRI is something that we typically include in our staging workup. I think here the diagnosis of poorly differentiated is a bit different than anaplastic in consideration of targeted therapies to use. So in the case where this is obviously not surgically resectable, we would definitely be considering looking for targeted therapy. And we also send off these biopsies for full sequencing, and we use like a targeted panel similar to what you've sent. And BRAF mutation is the first thing we look for, which in our experience now is about 40% of our patients who have anaplastic are BRAF positive. In poorly diff, our numbers are not as clear. Those are, we don't see as much as ATC these days, but probably similar to somewhere around there as in PTC. So in this case, I think given that it's not surgically resectable and it's BRAF negative, the NTRK fusion is interesting because we do have FDA approved therapies for NTRK fusions. These are extremely rare. So you, was that a fusion you said? What was the part? Yeah. Okay. So what was the fusion partner, do you know?
I have to go back and look it up. Let me, while you are, let me see if I can find it. Continue. We just gotta check.
So the NTRK fusion is a bit tricky because there are different ways to test for fusions. You can do a FISH, for example. Here we tend to favor RNA-based assay for fusions. We find that to be more accurate. And the experience with targeted therapies in BRAF positive thyroid cancer depends on the grade. So in anaplastic thyroid cancer, BRAF positive patients respond very quickly to BRAF inhibitor. And in papillary thyroid cancer, it really varies. So we find that in general, patients that just have BRAF and no TERT, they respond somewhat, but typically not enough to make any meaningful difference in terms of resection. If they do have BRAF and TERT mutations, they tend to respond more favorably. And poorly differentiated is somewhere in between, where they probably don't respond as well as ATC. But they respond a bit better than papillary. So now with NTRK, our experience is even less, meaning that we probably treated less than 1 or 2 of these patients in recent years. So it's difficult to kind of predict how they will respond to NTRK inhibitor, particularly if it's poorly differentiated and not anaplastic. But in this case, you know, the only other option would be to proceed with chemotherapy and radiation.
Yeah. Mm-hmm. Okay, so the answer to your question was a ETV6 and NTRK3. Yeah.
Okay. So those that would be a fusion that would be considered targetable.
Okay, so in the interest of time, same discussion here. I discussed with Eric, and we all agree that it is good news for him. But as you said, there is very limited evidence. And it wasn't strong enough for us to recommend just starting with targeted therapy to see what happens. So we, the tumor board and all of us recommend that you continue with the standard for poorly differentiated, which is radiation plus Adriamycin for 4 course and see what happens. I don't know what will happen. We'll see if it responds. I'm not very optimistic. But if it does respond, you know, it's good news for him. And obviously, the second line would be the NTRK inhibitor. I can never remember this name, Davorafenib or whatever that is. But that you can do that. So just wanted to give you an update for the group, and thank you, Jennifer, for your expertise. That we do have these options now. Sorry, I'm talking too fast. I'm just trying to get to the next case. But thank you again. And so remember, now we have options. It's very, very important in 2020 to have adequate diagnosis. And I think Jeff was kind enough to post the NTRK paper again for those of you. Unfortunately, the 75% response was not, I think the thyroid ones were not as good. There were other tumors that had much better response. And that was the other factor. All right, Arno, it's all yours.
Okay, well, we have just 4 minutes left, so I'll keep this pretty brief. But
That's what happens with trying to be ambitious. And Chad puts out like 200 pre-flap cases.
I know. Sorry about that. Yeah, no problem.
No worries, no worries. It's all good.
So this is just a couple slides from a case I was asked to be involved in on Monday that I thought I'd show you guys briefly. So this was, am I sharing my screen?
Yes.
So this was a 62-year-old male who I was asked to be involved in a surgical case from thoracic surgery. 62, otherwise healthy guy. I presented to his PCP with a couple-month history or 1 month history of numbness in his right 4th and 5th digit. The physical exam was notable for a little bit of right eye ptosis. His motor exam his strength was intact, but he did have subjective diminished sensation over the 4th and 5th digits. He underwent a C-spine MRI per his PCP that demonstrated what they call an incompletely evaluated right lower neck mass extending into the upper chest. And the radiologist recommended definitive imaging with an MRI, contrast-enhanced MRI, and a CT with contrast as well. So can you guys see these images?
Yeah.
Okay, great. So
are you playing radiologist today too?
What's that?
Are you playing radiologist today too?
I'm playing radiologist as well. So here's I'll scroll you through the contrast-enhanced CT scan on the left side of the screen. So you're seeing this kind of non-enhancing mass here that's pushing behind the trachea and deviating the esophagus to the contralateral side.
Oh boy.
The arrow here is pointing to the vertebral artery, so that's really displaced pretty far anterior. The vertebral is really kissing with the carotid.
Mm-hmm.
And then extends down into the upper thoracic space,
Jesus.
pushing the lung inferiorly. So big mass MRI scan. This is contrast enhanced MRI scan, and you can see that there's some widening of the neural foramina here. And then, so really widening what the radiologist called is at the T1 level. So the next step was a CT guided biopsy. And the CT guided biopsy was consistent with, if I can pull that report up, they called it a fibrous lesion, consistent with, they called it fibrous tumor or fibromatosis.
Any history of an F1 or an F2 in this patient? 60-year-old?
No history of NF, no personal history, no family history of NF.
Huh. Oh boy.
So the neurosurgery saw the patient, I saw the patient, and thoracic surgery saw the patient. I was asked to manage the neck for potential surgical resection.
Was that an FNA or a core?
That was a core biopsy.
I guess in the interest of time, if the fellows want to, Arno, you proceed, and then after hours, we will just have open the floor for others who would like to stay on and comment. I definitely want to hear more from other attending how they would approach these. These are rare cases, and I'm definitely going to learn. So you go ahead first, and then we'll all discuss it and see if others have any comments.
Yeah, so this is not something I'd ever encountered before, and so I was eager to hear what people's thoughts were in terms of approaching it. It seemed like a nerve sheath tumor of some kind, obviously with the widening of the foramen there, neurofibroma or schwannoma. The core didn't definitively show that, but we proceeded under the assumption that it was because the imaging findings were so specific. We basically I did a low collar incision, and then we did an upper clamshell thoracotomy, that came down between the 4th and 5th rib. We divided the SCM and the straps off of the clavicular head, and then they used this looked like a medieval torture device with this big hook that basically just ratcheted up the chest on that side. And
the vertebral was a big concern of mine there. You know, I don't know, I'm interested to hear if people have experienced sacrificing the vertebral or whether they prepare for that or sacrifice that. We had a vascular surgeon who said that it looked like the non-dominant vertebral and that if we had to ligate it, we should. We were able to trace it out of the tumor successfully. It was about 270 degrees encased. You could see kind of on these images that it really had to be kind of.
Is that the brachiocephalic vein or artery that's up there? Were they okay?
So the subclavian artery here,
sorry.
Yeah, here was
yeah, right there.
Basically, this thing was kind of dumbbelling a little bit around the subclavian. Yeah.
Just as kind of a pre-op question or two. Sometimes these solitary fibrous tumors on the spectrum of sarcoma or malignant nerve sheath tumors. And I'm just wondering whether, you know, an incisional biopsy and or metastatic workup or some sort of imaging of the chest, just things like that I would kind of think about, especially with something growing into the neural foramen like that, and a complete resection being somewhat challenging.
Yeah, no, absolutely. I think it's a great point. So he did have a PET scan, which showed basically a low avidity lesion, no other sites of disease. And on opening, basically on getting onto the surface of the tumor, I did an incisional biopsy and took it down to frozen section. And at that point, they felt much more confident that it was a neurofibroma and not a fibrous tumor.
Okay, cool.
A question for Elson very quickly. Would any other imaging modality would help in these situations to differentiate preoperatively? Do you have any other fancy stuff?
In terms of differential diagnosis, no, but preoperatively, we routinely perform brachial plexus MRI here to try to identify the nerves and provide some sort of surgical guidance.
Okay, great, thank you. So Arno, tell us, how did you approach the rest of the case?
So from a cervical standpoint, I dissected free the vertebral artery down to its insertion on the subclavian. We found the vagus and the carotid, and basically medialized all those structures. And actually this retrotracheal component actually delivered very, very nicely once they were finger medial to the lateral to the trachea. Then the vascular surgeon dissected free this subclavian vessel. And a neurofibroma, I haven't done many of them, but my experience generally is that they're like fibrous tumors. They don't have a very nice plane between. It's not like schwannoma that tends to deliver much nicer. So it's a very tedious dissection. The subclavian artery sustained, I think, 2 or 3 puncture wounds during the dissection that required oversewing. And the vertebral actually, in time, started to fatigue just with the level of retraction. And actually, by the end of the case, it looked so damaged that we ligated and sacrificed the vertebral.
And in my N of 1, I had the same experience, that these are very sticky, and they kind of, you're absolutely right, they don't have that nice plane around them, and they are really, it's hard to kind of dissect the vessel out of them. And as you said, exactly, once you do that, even the vessel gets really beat up. And I'm really interested to hear, so what happened? How did they finish the case, and what was the end product?
So then laterally we found the brachial plexus and the phrenic. And this thing's basically squeezed between, the vagus and the phrenic. And so both are being retracted medially and laterally. So there's a lot of kind of, prolonged stretch on those nerves during the course of the procedure. Ultimately, it's not something that we could take out on block because it's so stuck to everything. And so we basically did a piecemeal resection, starting from the thoracic component, dissecting it out, and then just followed it up basically into the neck, and then just dissected it, and then just basically debulked it down to the neural foramina. So it was just tedious, slow. It took 8 hours to get the entire thing out finally. And we left, I'd say, a rind of neurofibroma tumor posteriorly on the spine. But otherwise, it went well. I mean, his phrenic is out just from traction. but otherwise he's neuro intact.
Is the vagus intact? And how's his
Vagus
is
is
it
intact. Yeah,
yeah.
regular
The
plexus.
swallowing?
Swallowing fine, just uncomfortable.
Wow. Well, that's as Pete used to tell me, that's success. All right. Well, open for this kind. I'm really interested to hear others' comments. Mike, Jeff, Dr. Rich, Don, Chad, Jennifer.
I don't have a whole lot to add. I mean, I think the important thing that was pointed out by Arnold is really trying to make every effort to identify the pathology, even if you couldn't get it preoperatively, at least intraoperatively. I think you want to make sure, most importantly, it's not a lymphoma, which is not, it's this fibrous tumor. But even intraoperatively, if you're dealing with a malignancy, you may feel either more inclined to be aggressive or even less inclined to be aggressive because at best you're going to get an R2 resection, and an R2 resection leaves cancer behind. It may not be worth all the engendered morbidity when you might need some other non-surgical modality for treatment. So I applaud the strategy of trying to get as much preoperative identification of the tumor and then subsequent intraoperative identification of the tumor.
Yeah, very good point. And I think that move that you made, Arno, to actually get a frozen section in the beginning of the case was very important, and I applaud that. Others comments?
I was gonna kind of echo that, and some of these, depending on the pathology, there's some TKIs which actually show pretty good efficacy in desmoid tumors and aggressive fibromatosis. So confirming the pathology is paramount.
Yeah, absolutely, very true. Charlie, what do you do? Call Ezra Cohen right away?
I'd call Dr. Bewley. Say, Arno, get on a plane, fly down. No, that all sounds, spot on.
With vertebral, vertebral artery, we don't often think of in salvage neck, but if you're low enough in the neck, the vertebral artery sometimes can be pretty close to some.
Yeah, very true. Very true.
That was one thought I had, was whether it, in consultation with the vascular surgeon, might be worth preoperative stenting. Which just doesn't guarantee you safety by any stretch, but it may help your confidence.
Is that big enough for a stent? That seems to be pretty small, but you might be right.
It's not the most impressive vessel, when you have it stretched out.
Yeah.
Yeah, we can.
For some reason,
but if they can put stents in the coronaries.
Yeah, that's true. For some reason, neurosurgeons are very uncomfortable with taking the vertebral, and they always try to save it. I think it's a little bit unpredictable how the patient reacts.
Yeah, I looked in the literature in terms of pre-op balloon occlusion. Even I found some studies supporting, and the literature seemed to be all over the place. There were some series of 15, 16 patients where vertebral artery sacrifice was tolerated in most patients without any pre-op testing. There was other series that described an up to 40% risk of some type of stroke event afterwards. And so I was very interested to hear if anybody had any practical experience or guidance, because I didn't feel like I had prepared myself well enough for that aspect of it by the time, when I was staring at this thing.
No, these are tough cases. Anybody of the other attendings on call would like to make any comments?
What is your final path? I didn't hear that. Do you have confirmation of neurofibroma for that entire mass?
So this was Monday. The piece I took in the superior aspect of the mass was consistent with neurofibroma, but I don't have final path yet since it was just.
So I would just add that in an elderly patient like this who presents with symptoms of numbness and a mass this size that was otherwise unknown, is that correct? It was unknown prior to the numbness?
Unknown prior to the numbness.
Yeah. I honestly think that's a neurofibrous arc, and you're going to find it somewhere in that large tumor. And I think, if you knew that ahead of time, and obviously you've proven that it would have been almost impossible to determine that if that's what he had without resecting it. I would say if you knew that that's what he had, chemoradiation and then surgery with more chemo is probably how we would have managed that. So just a thought.
Do we have any specific agent for fibrosarcoma? I can't remember. I always rely on my medical oncologist, but sarcomas are tricky when it comes to chemo as well. Well, I hope it's not neurofibrosarcoma because that,
Yeah.
for lack of a better word, that patient is toast.
Yeah, I mean, certainly during the debulking, it was large. The degree of vascularity was really minimal. It just seemed like a big kind of degenerated kind of hypovascular.
Fibrosarcomas are, I think fibrosarcomas would fall under the low-grade sarcoma group, and therefore usually not as much chemotherapy-driven as surgical resection-driven, which makes this case particularly difficult. It's not like osteosarc or one of these more aggressive, like a rhabdo, where
you can absolutely have grade 3 neurofibrosarcs. I'm operating on one next week after combined chemoradiation in a 15-year-old. So neurofibrosarc. So I mean, it's what they can do. But I'm interested in our medical oncologist's opinion because I'm certainly no expert there.
Yes, true.
Most of the time, we see FDG uptake in neurofibromas going sarcomas. So we do sequential follow-ups for these patients, and this patient had PET-CT, I remember.
Yes.
Right. So, and there was no FDG uptake. Most of the time for sarcomatous degeneration, we do see increased FDG, at least differential increased FDG uptake, and we always target that portion when we do the CT guided biopsies.
Okay, great point. Great point. All right. Any other comments? Great case. Arno, would love to hear the final pathology later.
Yeah, I'll give you guys an update.
See what it is. It's great. Well, it's according to Arno's clock, it's 5:13. I'm really jealous, by the way. But it's 8:13 here in New York City. Thank you all. Thanks all the panelists for fantastic conversation and cases, specifically Dr. Kofi, Dr. Zander, and Arno for last minute. Thank you to Dr. Reed and Dr. Ridge, and also Jennifer, Dr. Wong for participating in Tumor Board, and Nelson the last minute. This was a fantastic conversation. To all the fellows who were here, thank you for your participation. This was the end of 1 month with our pilot project. We're going to send you a survey. Please let us know what we can do to keep these going, or you're just sick and tired of us and want to have better things to do on Wednesday night. Thank you all. Stay safe.
We have one more next week, Babak.
We'll do one next week. All right. Have a great night. Thank you all.
Thanks, guys.
Thank you.
Bye.